So this talk is on intraventricular hemorrhage. This is one of the most common complications that we come across in an ICU, especially when we deal with extreme preterm babies. The incidence of IVH has come down. Probably if you look at in late 90s or 80s or 90s, it has come down due to certain interventions. But beyond that, in the last 1 decade or 1.5 decades, the incidence of IVH has remained pretty much same in spite of the various advances in neonatal care. So, and the implication for this intraventricular hemorrhage in these extreme preterms with significant impact on the neurodevelopmental outcome is very important. So the points that I thought I will focus on in this brief talk is about the pathogenesis. I will just touch upon the pathogenesis of IVH, when to intervene. By when to intervene, I meant like in the post IVH complication, post hemorrhagic hydrocephalus. The $1 million question is when to intervene, when to sit and watch. The third point is how to prognosticate, because we keep counseling our parents in an ICU with each scan, and based on the evidence, how do we counsel the parents for different grades of hemorrhage. And finally, how to prevent or decrease incidence. I will just briefly touch up on it as well. Coming to the pathogenesis and the classification of IVH, the standard classification that we follow. Grade 1 IVH, where the hemorrhage is restricted just to the germinal matrix. Grade 2 hemorrhage, where the hemorrhage extends beyond the germinal matrix, but less than 50% of the ventricular cavity, and with absolutely no ventricular dilatation. Grade 3 hemorrhage, where the extent of the hemorrhage goes beyond 50% of the ventricular cavity, or when it is associated with ventricular dilatation. Grade 4 IVH or periventricular hemorrhagic infarction is caused slightly with a different pathology, but it is mainly a significant intraventricular hemorrhage associated with a large parenchymal infarct, as you can see. So that is the picture on the cranial ultrasound scan on a sagittal section. The left top picture shows a small bleed in the germinal matrix, which is the typical grade 1 hemorrhage, which we most commonly see in our preterms. Grade 2 is in the right top corner. You can see the bleed is extending beyond the germinal matrix, but it is less than 50% and there is no ventricular dilatation. The picture on the left lower corner is, you can see a significant ventricular dilatation along with a significant bleed, which is much more than a grade 1 bleed, and that is a grade 3. And on the right lower corner, you can see the typical periventricular hemorrhagic infarct. You can see a significant bleed in the ventricle. Along with that, you can see a significant infarct in the parenchyma. So what causes the IVH? The germinal matrix, that is the area in the lower part of the ventricles, which actually synthesizes or produces during the fetal period the neurons, the glial cells. That is the area which is very cellular and very vascular at the same time without much supporting system. So it is a very freely floating area, which is supposed to involute around 28 weeks of gestation, and then by term it should disappear completely. Because of the fact that it is very vascular with thin capillaries, thin-walled capillaries, it is a ticking time bomb. Any small stimulus can cause it to explode, releasing and resulting in an IVH. The second most important factor is the lack of cerebral autoregulation. As we know, in extreme preterms, the ability of the cerebral vasculature to control the flow is minimal. So it is a pressure passive circulation. Any minor changes in the pressure, in the blood pressure, any minor changes is directly reflected into the cerebral vasculature, thereby adding on fuel to cause that explosion. So in our typical extreme preterm babies who are having RDS, who are going through mechanical ventilation, who needed resuscitation, who tend to have blood pressure variations, who have fluid boluses, all of these impact on this cerebral vasculature, resulting in the bleed. Other than this, there are significant studies that is going on to look into the genetic factors. There are no conclusive evidence so far, but there are many case reports based on genetic factors that is predisposing to intraventricular hemorrhage. For example, the mutations in collagen have been published to be associated with recurrent and significant IVH. There has also been ethnic more preponderance in mothers who are from African descent. It has been shown to have an increased incidence of more severe bleeds in that. So that again could be a pointer towards genetic factors determining the incidence of intraventricular hemorrhage. As I said before, the grade 4 or periventricular hemorrhagic infarct, the mechanism is slightly different from the other grades of the intraventricular hemorrhage. You can see the medullary veins. Those are the veins which drain the white matter. They join to form the terminal vein, and this terminal vein passes through the area of germinal matrix. So when there is a significant intraventricular hemorrhage in the germinal matrix area, it compresses and causes an obstruction in this terminal vein, that resulting in a significant back pressure, causing a significant hemorrhagic infarct in the brain parenchyma. And this is the etiology for grade 4 hemorrhage or periventricular hemorrhagic infarction. So this is the nutshell of the pathogenesis for IVH. We have all that big risk of set of risk factors in our extreme preterms, from RDS to mechanical ventilation to unexpected resuscitation, more significant resuscitation efforts. Pneumothorax is a possibility, and fluid boluses. All these risk factors on one side, the pro factors that are there for lack of autoregulation and the poorly supported germinal matrix, leading on to IVH. So what is the incidence of intraventricular hemorrhage in our preterms? I mean, different studies quote slightly different figures, but this is one of the last studies from Australia. They looked at 2,700 extreme preterm newborns less than 28 weeks. The incidence of IVH was almost 1/3, 33.9%. And among this 33%, 21% were low-grade bleeds, which are grade 1 and grade 2 IVHs, and whereas the 12% was constituted by the significant bleeds, grade 3, grade 4 bleeds. This is again a graphic representation of the incidence based on the gestation. This is a center who actively resuscitates 22 weekers. So if you look from 23 weeks, the gray one is the low-grade hemorrhage. So if you look at 23 weeks, around 1/3 of the babies are having grade 2 IVH, whereas grade 3 to grade 4 IVH is constitutes around 15%. But as expected, the incidence of hemorrhage, as each week passes by, the incidence comes down. The black one is the cerebellar hemorrhage, which is missed in many cases, which is very significant, and some of the studies have shown it as an independent risk factor for neurodevelopmental outcome. It is significant mainly in 23 and 24 weekers, but I'm not dealing with cerebellar hemorrhages in this session. How do we manage IVH? In the acute phase, there is not much for us in terms of intervention. The basic principle is supportive care, maintain adequate ventilation, try to avoid any trigger factors that will exacerbate the bleed, trying to avoid the hypo and hypocarbia, maintaining a steady ventilation. Volume guarantee ventilation is always preferable at this stage, if possible. Avoid hypotension and hypertension. As much as possible, try to keep a close eye and try to avoid fluid boluses as much as possible. Correct coagulation abnormalities, if any. Insignificant hemorrhages, seizures can be an accompaniment, so prompt treatment of seizure management. So this is the nutshell of the acute care management when we see the incidence of intraventricular hemorrhage. But the more significant part of the management comes from following them up in a closely manner. This is especially important when the grades of the hemorrhages on the higher side, grade 3 and grade 4 hemorrhages. It is very important for us to closely monitor them. So I would do a twice weekly cranial ultrasound scans, serial monitoring of the head circumference, and this is the question that we need to answer: to intervene or not to intervene. What is our cutoff point? So while monitoring, what do we look out for? So what is the natural cause of this kind of severe bleeds and post-hemorrhagic ventricular dilatation or post-hemorrhagic hydrocephalus? 40% do not need an intervention because they go into spontaneous arrest, whereas 10% goes into a rapid progression phase. This is the ones which we have to pick up early on and intervene very quickly, whereas the other half are persistent slow progression. So these are the ones which we keep on monitoring, we keep on intervening depending on our cutoff thresholds. In this 50%, 20% of infants can be managed with lumbar punctures and CSF drainage, which I'll come to in a minute. But 30%, this is the crucial bit where we need the help of my colleague Dr. Powis, who is the neurosurgeon. It is very important that we are ready for this backup who needs the shunting, because the delay, any delay in this kind of interventions can result in long-term outcome, which we'll come to in a minute. So how do we monitor? Ultrasound is the most useful method in monitoring these cases, and the most common parameter that we use to monitor these cases is the ventricular index. The ventricular index, we do a coronal session at the level of foramen of Monro, and ventricular index is measured as from the midline where the fox is to the outer end of the ventricle, and it is expressed in millimeters. The other parameters that we use are, one is the anterior horn width, which is a diagonal measurement, and you measure at the same view, in the same view, but diagonally, from measuring the largest difference between the two walls of the ventricle, as shown in this diagram. The third one is the view in a sagittal view, that is to look for the dilatation which is more confined to the posterior part of the ventricles. So that is the thalamo-occipital distance. That is the distance measured from the outermost part of the thalamus, the junction between the choroid plexus and the thalamus, to the posterior end of the posterior horn of the ventricle. So these are the three main indices, among which ventricular index is the most commonly used one. Take clinical decisions. How do we know? Where do we plot? This is the classic chart, Levine chart. In the bottom bit of the chart, you can see the two lines, which is the lower one is the 97th centile line, and the one on the top is the 97th centile plus 4 millimeter for the ventricular index. So this is the part where we plot it, and the one on the top is for the head circumference, showing the different centiles for the head circumference. And these are the more modern ventricular index charts, the yellow one showing the 97th centile and the red line showing the 97th centile plus 4 millimeters cutoff. So what are the interventions? The interventions are the initial stage as the ventricular index crosses the threshold, which we will discuss in a minute, whether it is the 97th centile or 97 plus 4 millimeters. Repeated lumbar punctures. The lumbar puncture, the standard initial CSF we usually take is around 10 ml per kg, but it depends on the clinical stability of the child and the procedure. But 10 ml per kg is a reasonable amount of CSF to be drained in a lumbar puncture. We repeat the ultrasound the next day to assess what is the response which we had from that, and then we decide on further volume of CSF drainage. If we are recurring more than 3 lumbar punctures, if the ventricular indexes are progressively increasing after the lumbar punctures, and it is clear that we need more than 3 lumbar punctures, that is the point where we decide whether to go for ventricular access device. And from there, if it is still progressing, then the ventricular peritoneal shunt. I'm not going into the details, the indications of these. My colleague, neurosurgeon Dr. Purvis, will go into detail in the next talk on that side of things. So the evidence for when to intervene, the one study that looked specifically into this, that is the ELVIS trial, the early versus late intervention trial. They looked at 126 infants in these extreme preterm infants between 2006 to 2016, and they followed them up until 2 years of age. So they basically classified, they randomized this group into an early intervention group, where the intervention was initiated at a lower threshold. The lower threshold was decided to be 97th centile of ventricular index, or anterior horn width of more than 6 millimeters. And the late intervention was decided at the ventricular index cutoff of 97th centile plus 4 millimeters, anterior horn width of more than 10 millimeters. The first set of the primary outcome was the incidence of the need for ventricular peritoneal shunt or death. And the first publication, which came in 2018, did not show any significant difference in the combined outcome. But if you look at the shunt incidence, there was a lower shunt incidence in the earlier intervention group, but this was not big enough to be statistically significant. And obviously, more infants underwent interventions in this early intervention group because the cutoff is on the lower side. But along with that, they did another study. They did the MRI, term MRIs for all these babies. And this sub-study showed that there is less brain damage in those babies who were intervened at an earlier cutoff stage. So there was like less myelination delay, there was less thinning of corpus callosum, other indices, other subscoring for in the MRIs, and the ventricular sizes were also lower in the early intervention. So this gave a hint that it could show up. Whether this could show up in the clinical outcome, there is a chance that it can show up in the clinical outcome. So we waited for the 2-year follow-up outcome, which was published in mid last year. And in that, what the statistically significant improvements were in 2 factors. One, those infants in whom they needed to go on to ventricular peritoneal shunt, those infants in the early intervention group, even after going on for ventricular peritoneal shunts, the neurological outcome remained pretty much the same. It didn't worsen. In all previous studies, those babies needing a ventricular peritoneal shunt, the neurological outcome was significantly worse compared to the other cohort. But in early intervention group, the outcome was very similar to those babies in the same group without needing a shunt. Whereas in the late intervention group, the babies who needed a ventricular peritoneal shunt at 2 years, the neurological outcome was significantly worse compared to those who didn't need it. So this is a pointer towards the improvement in neurological outcome. They couldn't statistically prove that the babies who had early intervention had a better outcome compared to the late intervention group. That was mainly because the number was powered for the primary outcome of ventricular peritoneal shunt and not meant for the secondary outcome. So if it was a bigger study, it would have very likely shown a significance. But again, as any other studies, we will have to say we'll have to wait for studies with bigger numbers to get a conclusive evidence. But all these pointers, and they also showed that there is a significant trend in the improved outcome in early intervention. So my take-home message from these studies will be to go for an early intervention. So we won't wait till the ventricular indices to cross 97 plus 4 millimeters. Once they go above the 97th centile and that is moving towards plus 4, I would rather intervene early than late, weighing at these results. So coming to the next point, how do we prognosticate the outcome of the different grades? The prognosis is more well defined and more unanimous in the studies in the later, like severe bleeds, grade 3, grade 4 bleeds. In the EPIPHASE study from France, which was done much earlier, the person in grade 3 hemorrhage, the incidence of cerebral palsy was around 20% and around 50% in grade 4 bleed. And in the most recent ELVIS trial as well, in periventricular hemorrhagic infarction, the incidence of cerebral palsy was 56%, whereas in grade 3 bleed it is less, 8%. But again, that is the total. If you look at unilateral, bilateral differences, it could be a bit higher. It could be higher in the bilateral group. The majority of children with grade 4 hemorrhage had a unilateral cerebral palsy. The reason for it can be in many cases where there is bilateral grade 4 hemorrhages. That is one indication many units take for reorientation of care, especially in extreme preterm. Reorientation of care so that those babies do not survive in most cases, considering the significant bad outcome. But that is the unilateral cerebral palsy is typical in periventricular hemorrhagic infarct. In grade 3 infarct, majority of children had bilateral cerebral palsy. And this is the other study which was published in 2020. It is again showing similar results, around 58% in grade 4. And again, showing unilateral spastic cerebral palsy, 97% of cases with grade 4 bleed. Grade 1 to 2 hemorrhages, there has been different spectrum of reports in terms of outcome. This particular paper, which came early, showed that there is a neurosensory impairment, significant neurosensory impairment in grade 1 to 2 hemorrhages, and they even showed incidence of cerebral palsy in the early bleeds, even after excluding those with porencephaly and periventricular leukomalacia. But multiple studies that were published beyond that, I mean, these are the more recent studies, even those from 2013 and the last one from 2020. These studies do not show significant neurological deficits in grade 1 and grade 2. But most of the studies are unanimously, they have come up with this point, that because in these studies, these babies are very closely followed up, normally for their neurodevelopment, even those with grade 1 and grade 2 bleeds. And there is an increased referral of these babies to early intervention services. So that early, it is an important factor that to monitor these babies even with grade 1 and grade 2 bleeds and refer to them with early intervention services. And that extra, a little bit of extra support will help them to achieve normal outcome, that the bleed in itself doesn't increase or worsen the outcome. So my take on while counseling the parents is that in grade 1 and grade 2 hemorrhages, I counsel them as it is very unlikely that it will cause any significant impact on the baby other than the prematurity and the rest of the things. But again, we have to take it as case by case, and we closely monitor and refer them to intervention services if there are any concerns. With grade 3 and grade 4 hemorrhages, yeah, we can give more definite numbers to parents. I don't have much time left, so I'll just briefly pass by these two slides. The trying to prevention, the main the crux of one of the main intervention that has changed in the incidence of IVH is the antenatal steroids. It has significantly helped. Many other interventions, magnesium sulfate and propoetin, those haven't shown any significant impact on IVHs. Neonatal nursing care bundles have again shown to be very effective in decreasing the incidence of IVH. So this is one of the model of intervention in the NICU, which have proved to be effective. So it is basically addressing all those points which we discussed in the pathogenesis. So bringing it into the practical aspect. So trying to avoid rapid increases in the intravascular volume by limiting the infusion rate of blood products, which we do as a standard practice in an ICU. Limit the infusion time of saline boluses to 30 minutes or greater. Then avoiding the rapid changes in CO2 and pH. So while we are doing the bicarbonate corrections, trying to do it on trying to avoid changes, do it on a longer period of time. Delayed cord clamping, then midline head positioning for the first 7 days, minimal handling. That is, I mean, all of these need a very close association with our nursing team and the medical team, and it has to be, there has to be a repeated teaching sessions and orientation sessions to implement all of these. And in RDS, preferring more the targeted volume guaranteed ventilation, which will help us decreasing those sudden changes in CO2. So that is a very brief thing about the prevention of IVH. I will have a quick look at the Q&As.